Welcome to my Opthal teacher. In today's lecture, we're going to talk about the documentation of corneal pathology in the first part of the lecture and bacterial keratitis in the second part of the lecture. So let us begin. Um, the documentation of corneal pathology dates back to the 1970s or probably even earlier. And the first documentation methods used a dark black outline, circular outline for the corneal limbus and a dotted line for the pupillary margin. Now, some of the features that were noted, and remember these figures were mostly in black and white. Some of the features that were noted and graded accordingly included corneal scar, edema, infiltrate, abscess, and the corneal thickness. For example, in this figure, the capital S denotes scarring. The 2, 3, and 4 denote the grade of the scarring. Okay. P, A denote anterior and posterior cornea. A scar would be denoted by vertical hatching, edema by pencil shading, infiltrate by oblique single hatching, abscess by oblique double hatching, and so on and so forth. Now, Braun used a grading system to document the degree of change of any pathology in the cornea. So that's what these grades are for, 2, 3, and 4. That is the different degrees of scarring of the cornea. Another method, the Waring's method, which was later modified. Now, this one used colors and added position of the eyelids in the diagram. Now, what they did was they divided the cornea into 4 quadrants, right? Connecting 12, 6, 9, and 3 o'clock position, as you can see here. And each quadrant is further subdivided by dotted lines connecting the remaining clock hours. And this is the pupil, the round dotted circle in the center. So a color code, now this one is universal, okay? This is the color code that we use today in our drawings. So black is for scars, degeneration, suture, and contact lens. Blue is for edema. Edema can be epithelial, it can be stromal. If stromal, the DM folds you can show in the form of blue wavy lines, and the epithelial edema, the little bullae, can be shown in the form of round circles. Brown indicates pigment or iris. Some people also like to indicate the pupil in, a brown circle. Red indicates blood, that is superficial vessels, stromal vessels, ghost vessels. It could also indicate rose Bengal staining used in herpes zoster. Green indicates fluorescein, often used in staining of ulcers or abrasions. The lens is green in color and the vitreous is also green in color. Now this is to be remembered. This is important. Yellow or sometimes orange may be used for infiltrate, hypopion, and keratic precipitates. So this slide shows the universal colors that are used. For example, you see this diagram is showing you a corneal scar, which is in, um, dark, horizontal hatching. And this is probably a sort of degeneration. Both of them are shown in black. Then dystrophies, again, these are shown in black color. Bandage contact lens, you see there is this outline since the edge of the lens of the BCL sits outside the limbus, so it is shown in a dark black dotted circle. So that's black color. Then blue color is for edema, so wavy lines for DM folds, blue shade for diffuse stromal edema, and small blue circles for epithelial edema. Green color, remember corneal filaments also stain positively with fluorescein, so it's shown in green. Green means fluorescein. Green dot for punctate epithelial keratopathy, which is also fluorescein positive, and of course epithelial defects, which are fluorescein positive. Then red, again, red color, like in the previous slide, it could be rose Bengal or the blood vessels. This is just a repetition. So basically, the new thing here is the subepithelial vessels, which begin outside the limbus and they are wavy in appearance, whereas stromal vessels begin at the margin of the limbus and are in a straight line. The ghost vessels is in dotted lines and rose Bengal stain we've already discussed. So this is a composite diagram showing so many features. So they're trying to show a synechia basically broad-based synechia from 9 to 2 o'clock position. That's actually a festooned pupil that they're trying to show you, right? Then this one's a corneal scar shown in black hatching. These are iris nodules. So the iris is shown in brown. These are different types of blood vessels. This is on the conjunctiva, whereas these are the subepithelial and the stromal and the ghost vessels respectively that we talked about. The orange dots show KPs. The yellow deposit shows hypopion, which is basically infiltrate, and sometimes you may find hyphema, which is the accumulation of blood in the anterior chamber. Now, always remember to draw a slit view besides your frontal view. For example, in this case, there is a particular corneal pathology, say, and there is no ulcer, of course, there is a hypopion and there are pigments and KPs. It's probably a case of uveitis, anterior uveitis. So still they've shown the KPs on the cornea. So this is the frontal view. Now, in order to show the depth of involvement of the corneal tissue, we have to have a slit view, okay? So epithelium in a slit view is indicated by two lines. If there is a defect, one can show it here. Then different stromal opacities and vessels are drawn. For example, here they've shown an HSV scar. Now this is the stroma, right? The orange one is the epithelium, although it should not be orange. It is just shown by two black lines, right? So this is the epithelium. This yellow, the blue color is probably the epithelial bullae or the epithelial edema that they're trying to show. This is correct. Small blue circles. Now this one is an old HSV scar which is somewhere in the superficial stroma and it is shown in black. Then the hypopion, they've shown the hypopion in yellow or orange, and that's all right. KPs, again, the KPs are shown in yellow and they are shown stuck to the endothelium, and pigments are shown in brown. So basically this is to, when you look at the cornea, this diagram is showing you the exact location of the scar in the cornea, which is between the epithelium and the stroma, or you can say subepithelial or superficial stromal. That is why always include the slit view besides your frontal view to indicate the depth of the pathology. Now let us come to the second part of the lecture, that is bacterial keratitis. We will be discussing the first part, which includes the etiopathogenesis and the clinical course, that is the signs and symptoms of the disease. Investigations, complications, and the treatment will be discussed in the subsequent lectures. So some very important definitions often asked in Viva. So what is an abrasion? An abrasion is a superficial epithelial defect without any inflammation, and it usually heals in 12 to 24 hours by the regeneration of the epithelial cells. We read in the corneal anatomy that the epithelial cells can regenerate very quickly. Now, that was an abrasion. A loss of epithelium accompanied by inflammation in the surrounding cornea is a corneal ulcer. Inflammation would appear as a grayish haze or loss of clarity. If accompanied by outpouring of leukocytes, it is off-white or yellowish and termed as infiltration. So basically, an epithelial defect plus infiltration is a corneal ulcer. Corneal ulcers can be infective or sterile. If infective, you will find more infiltration. If sterile, you may not find any infiltration but just a hazy cornea, that is because of inflammation. So today we'll be talking about a type of infective corneal ulcer, that is bacterial corneal ulcer or bacterial keratitis. So what are the causative organisms? Now there are bacteria which can penetrate an intact corneal epithelium, and there are bacteria which are common commensals of the human body. Now these are the often the common causative agents also, the ones on the right side, and they usually invade the cornea when the host immune system is compromised, and as well as the local immune responses of the cornea are compromised. The normal commensals become pathogenic organisms. On the other hand, there are bacteria which can penetrate an intact epithelium. Very important to remember the names of these 5 bacteria, commonly asked question in Viva. So these are just pictures of, for example, this one is a picture of gram-positive cocci, which could be Staph aureus, Streptococcus pyogenes. Staph is a normal commensal. Streptococcus is also a normal commensal. Streptococcal pneumoniae, especially, is seen in the upper respiratory tract. Then we have Pseudomonas. Pseudomonas is a gram-negative bacillus. For example, here, these are gram-negative bacilli. They are pink in color. Pseudomonas is often present in contact lens wearers. Then there are Enterobacteria, which are gram-negative bacilli commensals of the GI tract. Now, these are examples of gram-positive filaments seen in nocardia, this one, and these are gram-negative diplococci, very typical of meningococci. Remember, gram-positive would appear purple and gram-negative would appear pink. Now, there are certain bacteria which produce a particular type of enzymes. Now, these enzymes basically destroy basement membranes and cause stromal necrosis. For example, Pseudomonas produces the given enzymes. Staphylococci is known for producing, notorious for hyaluronidase, coagulase. Streptococcus for streptokinase, streptolysin, and streptodornase, which are also the derivatives of certain antibiotics. So, what are the predisposing factors? Now, in India, with the majority of its population in the agriculture sector, a lot of injury with vegetative matter happens. So, in India, trauma, especially with vegetative matter, is one of the most common causes of ulcers, and they're usually fungal ulcers, but then, of course, they can have super added bacterial infections. Contact lens, remember Pseudomonas is notorious for causing eye infections in contact lens users. Drugs such as corticosteroids, which compromise the local immunity of the eye. Anti-glaucoma drugs, they often contain preservatives which are epitheliotoxic. Ocular surface disease such as dry eye, chronic blepharitis such as you can see in this picture. You see how much of crusting is there on the eyelashes, so that is very poor ocular hygiene. Trichiasis, entropion, I hope you understand the meaning of these terms. Severe allergic eye disease. Lag ophthalmos is inadequate closure of the eye because of Bell's palsy. Dacryocystitis, as you can see in this picture, is inflammation of the lacrimal sac which lies here. It's a constant source of infection to the surrounding tissues, immunosuppression, diabetes, and vitamin A deficiency. Now, very important, the pathogenesis of corneal ulcer. Now, more or less, this is the pathogenesis of any corneal ulcer, not just bacterial. But then these classical stages have been defined still. So, how does the ulceration begin? This is the pathogenesis on the side. Please correlate it with a diagrammatic representation of the stages through which an ulcer passes. And this is a diagrammatic representation of what all inflammatory cells and cytokines and interferons and whatnot is released locally in the stroma to cause that inflammation or infiltration that we talked about. So, it begins by a breach in epithelium with the localized necrosis of all the layers of the cornea, mediated by all these cells and toxins, bacterial toxins. This is followed by necrotic material and epithelium sloughing off, and a defect remaining in the stroma with purulent infiltration in its floor. You see that there are leukocytes, a lot of polymorphonuclear cells getting accumulated. So that they along with the bacterial remnants, the dead bacteria as well as the live bacteria, they constitute the purulent infiltrate in the floor of the ulcer. This one. This is the purulent infiltrate in the floor of the ulcer. The epithelium and a part of the stroma have sloughed off. Next, the epithelium regenerates over the edge of the ulcer, causing a saucer-shaped defect with edges projecting up above the surface. So basically, we are still in the progressive stage, but the epithelium is, trying to regenerate over the defect here. So the epithelial defect is actually smaller than the infiltrate below it. So this is the progressive stage of the ulcer. right? And this one would stain positively with fluorescein, this part over here where there is no epithelium, and the surrounding unstained area would appear grayish because that's all the infiltrate that has accumulated there. So this is about the progressive stage, right? A part of the epithelium and the superficial stroma is sloughed off, and necrotic material is present in the base of a saucer-shaped cavity along with the surrounding infiltration. Progressive stage. Then gradually healing begins. How does healing begin? By invasion of superficial vessels. We know that the cornea has uh, up to 2 it has vessels invading it. So from the periphery itself, these superficial vessels, they emerge, they grow further into the cornea. So that is abnormal vascularization of the cornea. Why? To provide antibodies and other factors to enable healing of the ulcer. Also to bring in leukocytes. So the surrounding area, the bacterial toxins are diffusing into the anterior chamber and causing inflammation, leading to anterior uveitis and hypopyon. So this is also a part of the progressive stage in which the bacterial toxins that are present in the stroma, you see they are very well into the stroma. Sometimes what happens is that the toxins, mind you, not the bacteria. Bacteria cannot penetrate that strong descemet membrane that is there. Okay, that serves as a barrier. When we read about anatomy, we read how strong and tough and elastic the descemet membrane is. So the bacteria cannot pass through, but the little toxin molecules can leak into the anterior chamber, inciting an inflammatory response to the iris and the anterior chamber in the form of anterior uveitis and hypopyon. So again, a part of the progressive stage. So as I was talking about healing, as healing begins, superficial vascularization develops, infiltration and edema start reducing, and the edges become smooth. So look at this now. You see how the edge has smoothened out from this jutting margin. It has become a smooth, sloping edge, and the infiltrate has reduced. Clinically, you will see this as an decrease in the size of the ulcer as well as the infiltrate. Followed by regression, regeneration of collagen and fibrosis happens, and finally the ulcer is healed, the inflammatory cells, the inflammation has disappeared, and a scar remains. The scar would be of varying density depending on the extent or the depth of involvement of the corneal layers. Right. Clinical features, I think you can very well imagine there is pain, redness, photophobia, that is intolerance to ambient light conditions. Why? Because of exposure of the naked nerve endings present in the epithelium. So, commonly asked question, why photophobia happens? Because once the epithelium is sloughed off, the nerve endings that we read about in anatomy, the naked nerve endings in the epithelium are exposed to the outside, so that irritates them. Blurry vision. Blurry vision can be because of this, you see this diffuse haze, that is because of corneal edema and mucopurulent or purulent discharge. Signs. Please remember these 10 signs of uh, keratitis, any infective keratitis for that matter. So conjunctival and circumcorneal congestion, hazy cornea, why? Because of edema, epithelial defect that stains positively with fluorescein, surrounded by infiltration. So this green zone that you see is the fluorescein, and the little grayish or whitish zone around it, that is the infiltrate. Hypopyon, you can see a hypopyon, a tiny streak of hypopyon. It is cut off in the picture slightly. So this is the hypopyon in the anterior chamber. There may be vascularization, encapsulated corneal abscess. Look at this. This is a corneal abscess. Prolapse of uveal tissue, you see, this is prolapsing uveal tissue. The ulcer has already perforated and the dark uveal tissue is coming here. This could also be a desmetocele. One will have to find out by using a slit. Then we can grade the corneal ulcer according to the size, depth, and infiltrate because it has a bearing on the prognosis. on the final visual prognosis. So it can be mild, moderate, severe depending on the size, 2 mm, 2 to 5 mm, more than 5 mm, depth of involvement of the stroma, 20%, 20 to 50, more than 50, and the characteristic of the infiltrate. For example, see a tiny infiltrate, okay, probably less than 2 mm in size, no hypopion, nothing, right? And it is also very superficial. Now look at this picture, it's moderate, right? There is a deep stromal involvement with surrounding edema. You see the haziness of the cornea, you see the surrounding infiltrate, right? This picture hasn't been stained with fluorescein, else this area would have been green in color. And there is a tiny bit of hypopion over here. And this one is even more severe, much more than 5 mm in size, more than 50% of involvement. It is accompanied by chemosis, which we cannot make out, but we can make out the scleritis. See how red the eye looks. The surrounding sclera is also involved. There might be eyelid edema, and complications of corneal ulcer are seen in case of severe ulcers. Now, certain special types of bacterial ulcer, for example, Streptococcus pneumoniae. It presents with a deep oval central stromal ulceration, as you can see here. There will be a leading edge and there will be a healing edge. If you cannot make out in this picture, remember that a leading edge or a progressive edge would be ill-defined and the healing edge would be sharply defined. And a hypopion is always more or less present. So that is Streptococcus pneumoniae, and this type of ulcer with one edge healing and one edge progressing is known as a serpentine or ulcer serpens. Staphylococcus aureus, often encountered in compromised corneas such as these. It presents with an abscess. Now, staph has a tendency to form abscess. So, marked suppuration, that is pus formation, and deep stromal abscess. So that was staph. Then N. gonorrhoeae. N. gonorrhoeae, remember, it is very rapidly progressive and causes a hyperpurulent conjunctivitis, marked chemosis, stromal infiltration, and rapid perforation, maybe even within 24 to 48 hours. Now, thanks to penicillin, gonorrhoeae, usually it is less commonly seen when compared to the other causative organisms. Pseudomonas aeruginosa, as we discussed, very commonly associated with contact lens users. It presents with a greenish yellow discharge. It is also rapidly progressive and causes stromal melting. Now you see this defect over here, this is basically melting. The stroma is melting away because of necrosis. And later on, it is likely to perforate. And you can also see the dirty mucopurulent discharge, how matted the eyelashes are. That's Pseudomonas aeruginosa. Nocardia species. Now, Nocardia causes an indolent ulcer or a slowly progressing ulcer after minor trauma, particularly exposure to contaminated soil. It consists of raised pinhead-like infiltrates in a wreath-like configuration and brush fire-like border. So basically, remember, a wreath-like configuration is usually seen in nocardia, and it is an indolent ulcer. It is not rapidly progressive, that unlike the ulcers that we just discussed. And then we have these non-tuberculous mycobacteria, which have a very particular feature of these spoke-like opacities, rather infiltrates, I'm sorry. So spoke-like infiltrates. The margins of the infiltrate have these little spokes. Remember, non-tuberculous mycobacteria are seen particularly after refractive surgeries such as LASIK. They are caused by contaminated instruments, and it is also a slowly progressive or an indolent type of keratitis. So that's all about today's lecture. In the subsequent lectures, I'll be talking about diagnosis, treatment, and complications of bacterial corneal ulcer. So that's all for today. Thank you for your patient listening.